Okay, thank you once again. It's my honor to be here presenting at Annabelle. It's one of my favorite places to come for conferences. The weather's nice, people are nice, food is good, and I thoroughly enjoy coming down. My talk today is actually a day-long event which ran into a period of a week, and it was one thing happening after the other, just something else taking place. And initially, we thought we're just going to have a straightforward TAVI, and we'd go from there. The day would be fine. We'd be just on our way home. So I'll just go over a little bit about TAVIs. I know most people here know about TAVIs, but just for those that don't. TAVI, or transcatheter aortic valve implantation, aka TAVR, transaortic valve replacement or implantation. The aortic valve usually opens when the blood from the heart is pumped to the rest of your body. Build up a calcification on the aortic valve leads to a condition known as aortic stenosis. This causes the valve not to open or close properly. Heart has to work harder and can result in various symptoms such as breathlessness, edema of the feet and ankles, chest pain, dizziness. Usual treatment for these patients with the aortic valve problems is open heart valve surgery. Some people may be considered at too high a risk for this procedure, so transcatheter aortic valve implantation may be the best option in these high-risk patients. This is a procedure that allows the valve to be implanted percutaneously with a long catheter through the groin, although there are other access sites may be used. The valve is made of tissue derived from cow or pig. The valve is passed through a catheter that has been inserted into the groin and guided to the aortic valve into the heart, where it's deployed through the native valve. The catheter is then removed, and the valve begins working right away. So simplistically, that's what a TAVI or TAVR is. This transthoracic valve has been proven to be have better results for the high-risk patients over conventional medical management when open heart replacement is not an option. Aortic stenosis is the most common valvular heart disease, primarily affecting elderly patients, but 4% of patients are over the age of 85 that are affected. In this population, those who develop symptoms have a very poor prognosis, with an increased mortality of 50% in 2 years if not treated. Superiority of TAVI over medical therapy after introduction by Cyber et al. In 2002 has been well established for patients with high-risk scores. So just different types of transcatheter valves are available. Many centers have routinely performed TAVI procedures with great success, however, it's not without risk or complications. In the event of complications necessitating the need for emergent cardiac surgery or crashing onto bypass, a disciplined and dedicated team need to act quickly to ensure a smooth transition to mechanical support. Despite the need for this treatment in high-risk patients, nearly 50% can survive. Some of the complications that lead to conversion to bypass include valve malposition, LV perforation by guide wire, annular rupture, valve embolization or migration, aortic dissection, RV perforation, pericardial tamponade, coronary obstruction or occlusion, LV perforation by delivery system, severe paravalvular leaks, delivery system problems, VSDs, LV aneurysms, and most complications occur acutely after TAVI procedures. So although these are done routinely and straightforward on a daily basis, they're not without risk. They're highly complicated procedures, and things can go wrong with these. This is an actual case of mine. It was the first one I had to crash on bypass with. It was the balloon annuloplasty ruptured, and we could not get it out of the aorta at all. We had to actually crash on, open the chest, and take it out surgically. So again, this is just to indicate valve malposition, B being in the correct position and the others not in the correct position. So complications can be classified as either cardiac or non-cardiac. Okay, so proper patient selection is essential in ensuring positive outcomes given the risks involved. A highly trained and dedicated team, as I mentioned, is essential. The team should consist of interventional cardiologist, cardiac surgeon, cardiac anesthetist, dedicated nursing team, X-ray technicians, control room technicians, and perfusionists. I know other centers have a different configuration, but this is what we use at our institution. Our center primes a bypass machine with all necessary equipment and tubing packs readily available in case there's a need to rapidly convert to bypass. We typically used to sit in the room behind the pump with lead on, but now we actually were in the control room. I don't know if that was a good idea or not. I would prefer to be in by my pump with lead on, but a lot of our guys will stay out in the control room and come in if need be. But I've crashed on 3 times, and when you're needed before now. So I prefer to stay in the room. So some centers use bypass for cardiac support most of the time. This leads to the question, if continued support is needed post-procedure, would ECMO be a better alternative for acute support in a TAVI procedure? I've done some reading on this, and not a lot. Some centers are using ECMO as opposed to bypass, and I'd like to look into this a little bit further because at our center, we keep a primed ECMO circuit outside the cath lab for every intervention that's there in case we have to go on ECMO. So it's already there, it's already available, it's already primed. So I certainly would like to look at that option down the road for our centers and maybe discuss with the parties involved and see if we do make a change or if we decide not to make a change. Advances in ECMO technology and improvement and available percutaneous cannulas make ECMO a valuable resource. It's also less expensive unless you're using what we use, and CenterMag, as everybody knows here, they can be up to $10,000, $12,000. We've been grandfathered, we're $5,000. So just for that fact alone, we've not gone that route, but doesn't mean to say we can't switch a device and actually use something that's a lot cheaper down the road. So we're certainly going to keep that option open. We made modifications and simplification to our ECMO circuits, and we made ECMO a viable alternative with questionable superiority over bypass. Some of the literature that's out there suggests that it is, and other people, I don't know if it's just because they're so used to using bypass, they think that bypass would always be the way to go. If, like for example, the first case that I did that we had to crash on a bypass, if you had to arrest the heart, that's where you're going to have an issue. But I don't know too many times even crashing on to people that have arrested. So I posed that question out to you guys afterwards. How many centers that have actually gone on to bypass have actually had to use cardioplegia? The patient can be resuscitated in the cath lab and transported to ICU with no interruption in support. This is our ECMO circuit, very slim, very modified, cut down. We do have access for CRT, as mentioned earlier in the day, and this comes with us straight to cath lab, transition to ECMO from bypass at present time, then we take them down to CVICU. Our TAVI Experience, first group of TAVIs were performed September of 2012, and stats for the past 3 years, 2015-16, we did 43 transfemoral, 3 transapical, and then we get out of that trend, 16-17, 57 transfemoral, 17-18, 38 transfemoral, and we've done 3 rescue TAVIs, and I've been involved in all 3. I was a primary perfusionist in 2, and somebody was at change of shift, and we're just going on for the second one. And all were performed in recently remodeled hybrid cath lab. Circuits primed with 1 perfusionist in the control room, but I'd rather stick around my pump if I got to pass lines up. I'd rather be available. And we use the Sorat S5 cardiopulmonary bypass machine, a crystalloid prime. No drugs are added at all at this point in time. No heparin. Our pouches for requests don't have any drugs in, so we just have the crystalloid prime ready to go. A recent event occurred at our institution resulting in malposition of the aortic valve, requiring conversion to bypass and ultimately transition to ECMO support. As mentioned, malposition is a serious complication for TAVI procedures, and the valve can be deployed either too high or too low. Too low deployment, low implantation is usually associated with moderate to severe aortic regurg, and TE can confirm the nature of the regurg, paravalvular or central. This condition may lead to hemodynamic instability or collapse. 2 main techniques have been mentioned in the literature to either reposition the existing valve or deploy a second valve through the first. Using fluoroscopy technique, a lasso can be used to spirally reposition the valve more proximal. And I can tell you right now, that is not easy. That's almost impossible. It was a nightmare. That was the biggest part of this nightmare going, trying to get these little snares on for like 2 hours, trying to get in position and reposition that valve. It was chaos. So using 2 lassos is not recommended, as it may apply too much axial force, resulting in ejecting the valve into the ascending aorta. Oh, that's what happened. If this technique is unsuccessful or too risky, a second valve may be deployed through the existing valve in a higher position. High implantation is also possible, but for the purpose of this case review, it will not be discussed. So I'll stop there with the actual TAVI stuff, and we're getting at the case report coming up. So we have a 79-year-old male admitted June 17th, 17 for a planned TAVI procedure. Past medical history, severe heart failure, history of ischemic cardiomyopathy with an EF of 15-20%. Severe aortic stenosis, mild aortic insufficiency, atrial fibrillation, and conduction block, and had an AICD in. He previously had two cabbages, a cabbage by 2 in 2002 using Lima and Rima grafts, so he had live grafts. He also had abnormal kidney function and NIDDM, diabetic. So, recent visit to Capital Health for heart failure, exacerbated by respiratory infection and aortic stenosis. He presented to the emergency department with a 3-week history of shortness of breath, orthopnea, peripheral vascular disease, and with lower leg edema. He had a TE done on May 19th, 17. Results were LV systolic function was severely reduced, high LV filling pressures, mild to moderate mitral regurg, mild to moderate tricuspid regurg, mildly dilated ascending aorta, and mild aortic root dilatation. Cardiac cath was done on the 26th. It was uncomplicated. Results were dominant RCA proximally occluded, LAD proximal 50% attenuation, and 90% stenosis before small critical first diagonal branch, complete occlusion with filling, distal filling from previous graft. Stable but diffuse 3-vessel disease. As per discussion with surgeons and cardiologists, this was a planned rescue TAVI only if there was reasonable expectation of survival. This is what was discussed first, and this is what kind of gets you thinking about a lot of things when you actually, this has been discussed with an entire team, and this was the initial plan that we're looking at. This was expressed by the patient and family members that were present at the time for the actual consult. The patient was then admitted to the hybrid cath lab, prepped and draped in the usual fashion. Right femoral artery was accessed using ultrasound guidance. 2 per-closed sutures were placed for later percutaneous closure. Guide wires were inserted. Aortic valve was crossed without difficulty. The N4 Medtronic delivery system was used to deploy a 34mm Evolute R Medtronic heart valve. That's the delivery system. There's no significant movement of the valve post-deployment towards the left ventricular outflow tract. TEE and aortogram confirmed too low ventricular deployment with severe paravalvular leak. Decision was made to attempt to snare the valve with 2 end snare graspers via 20 French femoral arterial sheath. This took literally hours to try and get this out. So this patient came into the room around 8 o'clock. We're now up probably around noontime with this still going on. There was significant bleeding noted from the inlet of the arterial sheath, and when I say significant, it was liters of blood lost at the time. So we had to get a cell saver, prime up cell saver, pass it up, and we ended up giving back to the patient 1,412 mils, and that was took about 15-20 minutes to get the cell saver up, get it in, so they lost blood prior to that, so they've lost a lot of blood at this time. So during attempts to reposition the deployed valve, the valve was dislodged and was situated in the aortic root. The valve was then redirected to the ascending aorta. This was very tenuous and very time-consuming. So that's now the valve migration. A 20mm French sheath was inserted via left femoral artery. 2 per-closed sutures were placed for later closure. After repeated attempts, a long exchange wire was passed through the embolized valve. Getting the new exchange wire in took over an hour to get the new exchange wire through that valve. A second Evolute R valve was prepared by the delivery system. A 34mm, again, Evolute valve was successfully inserted and positioned through the first valve. The TAVI team agreed that the placement of the valve was in the correct position. Second valve was deployed. During the deployment, the valve appeared to move ventricularly again. TE and fluoroscopy again confirmed the valve was positioned too low. Again, it was confirmed that there was a large paravalvular leak. The result was suboptimal and appeared to be too low ventricularly. Attempt to reposition the valve again. Second valve. After many attempts, the team was concerned about possible dislodgement of the valve with aggressively trying to reposition. While assessing the valve using TE and fluoroscopy, the patient became very hemodynamically compromised, developed arrhythmia, tachycardia, hypotensive, severe blood loss, required increased use of PAC cells and inotropic support. So the patient was crashing big time. Cardiac surgeon requested to emergently crash on bypass. Moments later, the patient went into VT and condition continued to deteriorate. Bypass machine again was Sorent S5, which had been previously primed and brought to the table. 10,000 of heparin was given to the circuit, and magnesium and dextrose and calcium were added to the delivery pouches of the Quest system. Lines were passed to the surgeon via clamshell, and a 19 French Medtronic femoral arterial and 21 Medtronic femoral venous cannula were used. Cannulation sites were right femoral artery and left femoral vein. 30,000 of heparin was previously given by anesthesia. Cannulas were inserted. Bypass was initiated. We had flows of 3.4 liters per minute, sweep gas of 2.4, and FiO2 was 58%. So the first gas that was drawn, this was drawn just before going onto a bypass by anesthesia. And pH was 7.22, CO2 was 35, PO2 was 360, sodium was 136, K is 4.8, calcium was good. So they're acidotic, but everything else wasn't too bad. 100 milliequivalents of bicarb was given, and 6 units of packed cells were given to the patient at this time, over a period of time. ACT returned at 714 seconds. 1330 bypass was initiated. Again, flows of 3.5, sweep gas of 2.4, FiO2 58%. Following initiation, the patient had stabilized, returned to normal sinus rhythm. Repeat gas was done. MAP was 56, temp 35.8, flows 3.5. pH was corrected, and all the other gases were, all the numbers were acceptable. A Sapien 3 29 millimeter heart valve was repaired, and it was repaired by a different cardiologist. So we now had 2 cardiologists attempted to put in the Evolute valve, and this time we had another cardiologist who was more familiar with the Sapien. He came in and he actually prepared the Sapien, and he was the one that actually delivered the Sapien valve. So it was delivered via the commander delivery system. Valve was deployed, position was confirmed via arteriogram and TEE. The valve was in an acceptable position. It had 2+ paravalvular leak. It was thought to be mild or moderate. Patient required high inotropic support and was still quite stable. Markedly reduced AF, his EF now was 10%. Continued to have more dysrhythmias, and bypass run was 119 minutes. It was felt that the patient would not do well post-separation from bypass. A decision was made to transition from bypass to ECMO for continued hemodynamic support post-procedure. Surgeon went to speak with the family members about ECMO support, and the family had agreed to this option, and a prime circuit was brought to the room. 17 millimeter Biomedicus femoral arterial and a 21 Biomedicus venous cannula were placed with an 8 millimeter distal limb perfusion that we were talking about earlier, and for providing flow to the lower extremities. And it was the placement of this was used during using guided ultrasound. So we've seen this picture many times before, so that's just our limb perfusion. Cannulas were connected to the ECMO circuit. ECMO was initiated with flows of 3.5 liters as well. RPMs were 3,200. Heparin was reversed with protamine, and following initiation, no heparin was administered. There was still a large amount of blood loss from the catheter sites, so the 6 units, as I mentioned, were given over a period of time. As well, we gave back 1,412 mils from the cell saver. Post-ECMO, the LV was ejecting minimally. Careful attention was done to ensure the cannula sites were bleeding minimally, so we oversewed them and made sure that there's no leaking around the cannula sites, as little as possible. Patient was transferred to ICU without incident. They continued to do poorly during the post-procedure ECMO run, requiring high inotropic support. Developed ischemic right hand, bilateral fingertip gangrene, bilateral foot ischemia. DIC was confirmed by ROTEM. Sepsis, liver dysfunction, renal failure, 1 week post-op, post-diagnosed with a brainstem infarct and to CT for confirmation. The family elected to withdraw care post-confirmation of infarct. And this was not supposed to be a rescue TAVI. The ECMO was discontinued, lines were clamped, and patient was pronounced shortly after, and family was at the bedside. So in discussion, this was a very complex and difficult case, malposition of Evolute valves by 2, and crash on the bypass, and eventually ECMO led to a very complex series of events, intra-op and post-op. The Sapien 3 valve was eventually deployed with acceptable results. Although patient was successfully transitioned to ECMO support, the outcome was not positive, with patient having care withdrawn 1 week later. It brings about one major question. When do we decide how much care or interventions are acceptable, and at what cost to healthcare institutions and family? Was the chance of a reasonable quality of life predictable in this given situation? Many ethical decisions must be made during complicated procedures. A complete team approach is necessary to ensure positive patient outcomes. The unexpected may occur when least expected, and the players have to move quickly and safely to ensure transition from uncomplicated to complex procedures. The ability to carry out required procedures in stressful situations is mandatory, and all options must be weighed on a minute-to-minute basis and acted on quickly. And with that, I'm kind of a magnet for all kinds of bad things happening, even on bypass. You start to hear people talking, well, we don't need people in a room. You certainly don't need as many people that they have in rooms at times, but there's certain people that I think should be in rooms and should be handy, and I think perfusion should be in the room, not the control room. That's just my personal opinion. They could probably react quite quickly and get them on fairly quickly from the control room. I agree with that. But now you hear conversations with people, well, maybe we don't need a prime pump. It's like, whoa, okay. I've only had to do 3 crash-ons, and I didn't have a prime pump. You weren't going to save anybody. There's no way, shape, or form. It would have taken me too much time. You're already doing CPR on the patient. You're trying to get the cannulas up. You're trying to get the circuit prime. You're trying to pass them up to the surgeons, and they're busy waiting, yelling at you for it. So I think to even consider going that route is probably a step backwards. I hope that we never get to that procedure or to that type of a situation. I agree sometimes, you know, is it necessary to have 7 or 8 nurses in a room? Probably not. You need people that are specifically identified to do whatever role they're identified to do. Do you need 2 of them? I don't think so. But you do need a dedicated team. You shouldn't have the cardiac nurse doing interventional radiology stuff, and you shouldn't have an interventional radiologist doing cardiac surgery if you're going to go out, crash on the bypass, open up. So I think those roles are important, and they should always be maintained. Can they serve a dual purpose if they've been trained to? We've talked about all morning why training is so important, and what we're doing at our institution now, because we are doing more ECPR, and with TAVI's crashing on, we actually do a lot of simulation work. Once every 3 months, we have a full-blown high-fidelity simulation with a mannequin that I've developed that we can actually go on to bypass or onto ECMO. And then once a month, we usually do either a teaching session or a wet lab. And for pediatrics, we do a full-blown simulation session once a month. And we have once a year coming up shortly, we have a continuing education day, and we have a lot of great speakers that come, and we try to get a select speakers of events that have taken place that, you know, this is how we do it and how would you get out of it, and find out what's new in the world of perfusion and with TAVIs and such. One of the big debates that's hot out there now is heparin versus non-heparin. We have a panel that's coming up for our education day. I've got one perfusionist that's going to follow ELSO guidelines, and we've got an intensivist from CVICU for VA ECMO and one from Med-Surg Neuro. And they have their own algorithm, so it's going to be interesting to have a panel discussion with our group amongst that. Thank you for your time. Any questions?